Our medications and what we can use to treat our migraines, making sure that you're understanding the difference between like our acute treatment. So I'm actually having a migraine and I'm trying to abort that migraine from happening versus my preventative or my prophylactic treatment that I can have. I did have a question. Just again on here, making sure that you're understanding the difference between your first line and your second line. And if somebody has a comorbidity, that you can treat that patient with, one of these meds to try to treat those conditions. The question that was posed was like, hey, if I have somebody, like when I'm looking at my venlafaxine as second line, and typically when we're talking about if I were to take amitriptyline over venlafaxine, we probably typically would never do that unless there was a reason why they couldn't handle the venlafaxine last semester, right? But in this situation, if you have a patient that's stable on something, like in real world, because your exam question is going to be very straightforward. I'm expecting you to know the difference between your first line and your second line is what I would be testing you on. And if you could be giving this medication to someone who has a comorbidity. In real life, if you had somebody who was on venlafaxine who had depression and they were stable on venlafaxine, you're not going to take them off of venlafaxine to then try to put them on amitriptyline because it's helping with their migraines and their depression because they're already stable on their depression. If I'm depressed and I have suicidal ideations and all the things and now you just destabilize me because of my migraine, is my migraine going to matter if I'm not here? And the answer is no, right? So if they're already stable on a medication like their antidepressant, then you leave them on that because we can still have them on something that's helping prophylactically, right, with it. It's just now would be something that's considered a second line, okay? If it doesn't work, when you put them on that new medication, then what I would say that would be done is that I would try to pick another medication. So this is a situation where I would probably put them on two things because depression is something that is hard for us to get our patients managed on anyway. It's hard for us to figure out what works, okay? So if I ask you this, it will be a very straightforward question. It's not going to be that complex. It was just a good question to ask, like clinically in real life situations, like what would you do? I would not pull somebody off of something when they have mental complications already, pull them off of something and then try to mess with their regimen. I wouldn't do that. Okay. So looking at these are other medications that we have, a newer class gaining a lot of popularity now. These are going to be your CGRP antagonists that are available. When we talk about the mechanism in a little bit, but what you see here is that you have these medications that are more expensive. You see that they end in MAB. What is my MAB? Some of these, my MABs, what do they mean? My monoclonal antibodies. So these are just looking at different things that you can use prophylactically to treat your patients. So you have your CGRPs here and you have your triptans. When we're looking at these, I crossed out the top one because I don't want you to worry about that one. So you're just going down from there. All right, so I'm going to say brand names because remember how I told you some pharmacists and these generic names, we don't love them. Okay, so our Amavig is there. You have your Ajovy, Emgality, your Qulipta, and your Nurtec that are going to be your CGRP options that you have. And then with our triptans, we have some of them that we can also still use prophylactically, and some of these we talked about because we had them for our menstrual migraines as well. So you see you have Provotriptan, Naratriptan, and Zolmatriptan that are available. So pay attention to my drug options that I have and then looking at your comments to say, okay, when am I worried about this medication in particular? So when you see that polysorbate 80, you see that some people are they have hypersensitivity to that component. So when you're looking at your ones that have MAB at the end of them, that can cause that hypersensitivity reaction. And then if they had any type of event, so like there's cerebral vascular events, or make sure that you're watching out, or cardiovascular events, make sure you're watching out for also again your MABs. When you're looking at your Nurtec, understanding that you have a lot of interactions, so just remember interactions. One that we don't see often that's listed here is that PGP that you see, your P-glycoprotein inhibitor. So make sure that you're looking at that because we don't have a whole bunch of drugs that are processed or metabolized via PGP but you see it listed there. And then you see that I can use this in different settings. So some of our medications that we have, we can use them for abortive treatment, and we can use them for our prophylactic treatment. So this is one of those ones that is telling you like, hey, I can use it in acute and preventative treatment. I have that option to kind of flip back and forth. Looking at your triptans that you have available, make sure that you're, again, just remembering which ones that you're using for those menstrual migraines, like we talked about when we were looking at our abortive options. So that's the same thing that you're seeing listed here. And then because some of these do have a longer half-life, and if they were using them for a longer period of time, remember that we had our medication overuse headache. So that's how you're going to be making sure that you're delineating your charts whenever you're making them for studying. This is telling you our mechanism of action, specifically looking at your CGRP antagonist. So essentially, what we think is happening in migraines is that there is an increase in the CGRP, or your calcitonin gene-related peptide. And so that causes vasodilation. So if we antagonize that, remember we want to vasoconstrict, when we antagonize that, you'll see that the CGRP receptor activation is being blocked, and therefore we don't have that vasodilation. We can maintain that vasoconstriction if we need to. So that's all this is saying with your mechanism of action. Some of them, remember, had that MAB, so the monoclonal antibody, and then looking at your preventative, you can see that, and then some of our patients who have chronic, depending on how bad they are, we can also put them on this prophylactically as well. Again, when we talked about triptans, right, if one didn't work, we can try another. The same thing is happening with this. If one doesn't work, I can try another one. It doesn't mean that they failed the entire class of medications. So that's all this is saying. Here are some of the same medications that we saw, but a little bit more detail about them, and looking at the fact that these are injectable medications that we're using on these patients. When you talk to, bless you, some of the patients about this, they will tell you that it is a very painful injection. Some patients will leave it out of the refrigerator for a little while. They'll also try to put ice on the area that they're going to inject to see if they can numb it before they inject themselves. And whenever they're using these, they're auto injectors, so you press it and it'll go in, but they have to make sure that they're leaving that needle in there for the medication to go into that spot, like all of the medication to go in that spot. If they press it and pull it off, of course the medication is going to come out, okay? So just make sure that you're paying attention to that. So you have your erinumab, your firmanezumab, and your galcanezumab, okay? Amavig, Ajovy, and Galati. Most of these are on our formulary. You see that all of them are prophylaxis, and except for your Emgality, you have your prophylaxis and your treatment option with this one, okay? So prophylaxis and treatment. When we're talking about our cluster headaches, we're going to get into those. They're very, very painful and very difficult for us to treat with that. So that specific headache that we're using it to treat it is going to be your Emgality. So you're going to see that again. We have the syringes that are going to come pre-filled, so they're going to take the dose that is going to be of the syringe that you order. And then just make sure that you're understanding that some of these, again, they're all injectable. Some of them are more frequent than others, but for the most part, you'll see that they're taking it at least once a month. So don't remember all of the dosing, just remember that they're injectables, and remember which ones you're using specifically just for prophylaxis versus you having the prophylaxis and the treatment option for your Emgality, okay? So the formulation, all I want you to know is that they're injectables. They're injecting themselves, okay? All right, looking at your tension headache. So just a different type of headache that we have. Looking at this is one of the more common ones that you'll see, but it's kind of hard to differentiate these from your migraines. So when you're talking about this and when we're looking at the exam, I'm going to tell you what they have. Most of the time, these patients may not present with that aura ahead of time, and so you'll see where when you're doing this and you're trying to diagnose your patient, you're going to be snooping a bit to try to see how they're presenting with that headache so you can differentiate between your tension and your migraine. So again, this is just giving you background information. I will tell you what type of headache they have. So there's nothing really from here that you need to you need to know for my exam that you will probably see this again. Looking at your different options, so remember we have acute versus prophylactic with every type of headache that you're going to look at. So these are your different options that we have. All of these you see they're week 4 suggestions, but our analgesics that you're talking about, like when we're looking at our Tylenol and our NSAIDs, we can see sometimes where we can get some better response from our patients. So looking at physical therapy and like just telling them kind of how to manage their pain and things like that is what we're looking at with these patients. Now, because the pain is very bad for these patients, you will see where now we are talking about and leaning more so on our NSAIDs and our acetaminophen, okay? Making sure, again, that we're limiting how much we're using them because we have our medication overuse headache. So for this one, just remember, if you see anything with tension, that we're gonna be around that 15 days that we're worried about for them, okay? So with this, we're just trying to make sure that we can also release the tension or the stress that that patient is feeling. So if you can figure out what the source is, then hopefully we can limit how frequently they're experiencing this type of headache, okay? So physical therapy, you have different exercises, amitriptyline that you have that you can use, and then we have our ibuprofen. But again, sometimes this is just an uncomfortable state for our patients. Tylenol and NSAIDs are typically where you're going to go. Looking at your prophylactic treatment that you have available. So this is again for your patients who are having several of these tension headaches, or they're having pain that is very severe and they don't want to experience it again. You can see if you want to opt out or opt into giving that patient prophylactic treatment. But for the most part, what we're looking at is this patient is going to have a frequency that's more than 2 times a week. So that's very frequent, right? So if I did that, that's 8 days, right? 8 headaches that I'm having, headache days that I'm having. So when we're looking at this, just remember, if I ask you a question about prophylaxis, it will be based off of the frequency, which is 2, more than 2. Don't remember the dose of my amitriptyline. Just remember that this is one of our drugs that we like to use, in addition to us giving them something for their pain, which would be our NSAID or our acetaminophen. Amitriptyline for tension headaches, okay? Your titration looks kind of familiar, right? So I'm titrating every 2 to 3 weeks. Make sure that you're understanding that that patient is not going to see that full benefit. Sometimes it's going to take a little while for it to work, so that's where you see up to 6 weeks for them to see that full benefit and to start to see the decrease either in the frequency or the severity of that headache that they're experiencing. When you're looking at your adverse effects, anticholinergic effect that they have, potential weight gain. So just paying attention to those things that we've already seen when we looked at our amitriptyline. We do have the option of that nortriptyline that can be less sedating. So if you do have somebody who's going to work and they're telling you, like, and they're very sensitive to that amitriptyline, which we do see drowsiness occur with that, which is why we typically will give this at bedtime because of that adverse effect. If they cannot tolerate the amitriptyline, you can use your nortriptyline to prevent the sedation that they're experiencing. See other options that we have available here: mirtazapine, venlafaxine, gabapentin. I'm going to only ask you about amitriptyline if I ask you a question about this. I want you to know first line things for these, okay? So don't worry about those. Okay, our cluster headaches. When we look at our cluster headaches, these are again very severe headaches that happen in some of our patients. The mechanism as to how this happens is not very well understood, but this typically will happen in our patients in the middle of the night, where they will experience their cluster headache, and so what they're thinking is it may be related to their rhythm, like their sleep rhythm and how they're responding whenever they're going to bed. So I can go to bed, I'm perfectly fine, and then I might wake up with an excruciating headache. And sometimes these cluster headaches are very, very debilitating for your patients, and they're hard for us to treat and break them out of the cycles whenever they have these. Looking at, again, some of the information I just told you about, most severe, so more pain associated with it. Most of the time they're going to wake up, they're going to experience this at night. That's all I want you to know is those 2 things that are underlined there. Happening when it occurs, all that stuff is just background information for you. But most severe, happening to our patients overnight. This is why we have such a hard time treating them. the duration of this headache is extremely long. 2 to 3 months, 2 weeks to 3 months is typically how long these can last. So that is a very, very wide range. Again, a lot of the patients, by the time they get to you, they're going to just be like exhausted. They're going to be drained. They're going to be in a lot of pain because it's something that is happening literally every single day to them. So when you're looking at this, again, just make sure that you're understanding that this is a very, very long and wide range of when this can happen and how long it can happen. When we're talking about our treatment for this, make sure that you understand when we're looking at acute or abortive treatment, we're pretty solid on that. When it comes to prophylactic treatment, that's where it kind of gets hard, because you can have some people who can have a cluster headache and then they're fine for years and years and years. But it's 20 up to 20 years that somebody can go without having another one. So when you're trying to think about prophylaxis is like, do I want to put somebody on something and they could potentially not have another one for another 20 years and they have to take this medication every day? And it's kind of like a hit or miss. Okay, so looking at this, initially what I asked around about was that they say, oh, well, what I'll do is they have that first one, I try to do abortive treatment, and then I'll see how frequent it is starting to happen to my patients. Because again, some of them can have that one and they're fine, okay? So our treatment, when we're looking at this, we're kind of trying to support them in a way. And then we're going with our triptan, or potentially very old school with our ergotamine. So first line, most of the time, oxygen does a very good job and it does work. So we would give them oxygen to try to help relieve their symptoms that they're having. And then if that doesn't work, you see that we go to our sumatriptan. Remember, we had all of those different formulations, but when we're trying to treat our cluster headache, we're looking at giving either the sub-Q option, which is that injection, or giving them the intranasal option that we have available. We do see very good effectiveness in this, and we have a very good side effect profile when we're talking about using our sumatriptan. I want you to be familiar with the first line, which is our sumatriptan for this. Yes, we can use our zomatriptan as an alternative, but sumatriptan is our first line that we're going to go to. And then when you're looking at this and how it's administered, so typically when somebody has a cluster headache, it's going to be on one side of their head sometimes. And so you would give it in the nair that's on the opposite side of where they're experiencing the headache. So that's what this is just telling you to do on that, okay? So wherever I'm telling you I have a headache, I'm going to go on the opposite side, and that's where I'm going to do my inhalation. But I prefer my sub-Q in this situation over my inhalation anyway, okay? Looking at our last line, remember our ergotamines were the last thing that we were going to reach for. You see that we have, if we had to choose between our old ergotamine versus our 2.0 dihydroergotamine, we of course want to try our dihydroergotamine. What was my big side effect that I was worried about with my ergotamines? Ergotism, right? That vasoconstriction is clamping down too much, okay? When we're looking at this, the reason why I prefer my IV over my IM over my sub-Q is because my IV is going to act faster. But then you're definitely worried about and watching that those side effects, okay? So just making sure that you're looking at what our options are. You have your ergotamine, and then you also have your Emgality that was listed there with our cluster headaches as well, okay? So oxygen, sumatriptan, ergotamine, preferably your dihydroergotamine or your Emgality, okay? Your dalcanizumab. Those are our drug options that we have. The other thing from this that I want to make sure you're looking at which route you're going to choose, because you see that one is preferred over the other. Okay, so make sure that you're paying attention to that when you're looking at this. My prophylaxis of my cluster headaches. Remember, this was kind of like that hit or miss, right? Because I have 2 weeks up to 20 years, or sorry, 3 months that it can last, but I can have this happen again to me probably in 2 months up to 20 years, which is a huge range. So you're trying to say, hey, do I want to use prophylaxis, patient, provider conversation, and then this is depending on how many times this is happening. So again, you see that range of 1 to 8. in a day, but it depends on how bad that one was. So that's why I was saying for this prophylactically, choosing to do prophylaxis is a little bit more difficult in cluster headaches. But our drug of choice that I want you to pay attention to is going to be your verapamil. And then you can also see where we can use our steroids in conjunction with medications that are going to require some monitoring when we're looking at our lithium, or we can use our topiramate, which we used previously with some of our other conditions. So just make sure that you're talking about, like, my drug of choice in this situation would be verapamil, and I can use a steroid plus or minus an additional medication. And if I put the steroid with a medication, I will tell it like it would be a real one. Okay, I'm not gonna like make you remember what the other meds are. So verapamil, or I'm gonna use a steroid. Okay. Looking at some of the other options, and this is what we're comboing our steroid with. So you see that I can have that lithium also be added on to my steroid. I can also add it on to the verapamil. So let's say they're in a cycle and they're having that cluster headache, and you tried to break it, you got them out of their cycle, you treated them, and they decide, hey, I don't want to go through that again, I want my prophylaxis. So you can put them on verapamil, and let's say they have another cluster headache. So that tells you, hey, maybe my prophylaxis isn't working very well, and then you can add on the lithium to their treatment for them, okay? We don't love to give steroids for a long period of time, so that's why you see sometimes with that steroid, it's kind of like, you want their headaches to be pretty bad. Because when we talk about our steroids and our side effects for our steroids, you'll see how severe those side effects can be. Other medication that we also had that we can use with our steroid or with our verapamil would be our topiramate. So again, just slow titrations whenever we're talking about these. So just remember that you have verapamil that you're going to be using right here, or you can use your steroids, you can use your lithium or your topiramate. Okay? We don't want to use steroids for a very long period of time. Most of the time when we're trying to use steroids, it's like a burst situation. So if I had several clusters and they were very close to each other, and I was trying to break that from happening, that's sometimes where you'll see the verapamil with that steroid added on, but we try not to use steroids often. If we can avoid it, we avoid it. And then you see your Emgality down there at the very bottom, which we already talked about, remembering that it's an injection, okay? That's the end of our headache lecture. And then you have just extra information down here at the bottom. Are there any questions? Let me make a note real quick. If not, I can't see y'all's face, but I hear laughing. That's fine. Only make sure that I don't ask you any second line stuff. Okay. Yes.
Just to clarify, so for the prophylaxis, we're using verapamil. That can be monotherapy.
Verapamil can be monotherapy. You can add on steroids. You can add on lithium.
But that's
like
not like all. I'm not stacking.
No. Hopefully you wouldn't be stacking that. If you had to go more than two, and this is the thing I think that kind of becomes difficult with, if some of you choose to specialize, then you're going to be more involved in some of this stuff than if you don't specialize. Like you're going to be like, oh, I'm going to refer you to neurology because this is a them situation, right? So could they possibly be on more than 2 drugs for a prophylaxis? They could potentially. But if I were doing that and I was putting somebody on a regimen, I would probably get up to 2 and then say, okay, if these 2 things aren't working, let me completely switch my game plan and try something else. Does this Emgality work for this patient? Does me just using this other medication work versus me trying to keep stacking on? The more drugs you add for a patient, the less adherent they become. So then they're not going to take anything. And they're going to come and see you again anyway. Yes. Yes.
So would you say if they failed the ergotamine and the
do your osteoporosis exercise.
Those 2, the ergotamine and the one I can't pronounce because it hasn't happened to it. So that is they failed verapamil and
they failed your orals. So think of it as like you're doing something that's less invasive, because those are all your oral options. And then whenever you get to your ergotomy, just remember we don't love ergotomy, right? Because it has a horrible side effect profile. In your emgality, we're saving that last. One, it's newer, we don't have a lot of research, and then two, because it's an injectable. So a lot of the times when you get to injectables, people are less hesitant to want to use them because they're having to inject themselves with something. So that's why. But I think that will shift as far as the emgality to where people will probably start to use that more often, especially if they're having those frequent headaches. So if I ask you a question on this, I'm not going to ask you in a way of like, we've stacked all of these things onto this patient. Because depending on professional guidance, depending on a guideline, you will pick to do different things. So I want you to just pay attention to putting the drug with the condition, if that makes sense. But I'm not gonna like we're not gonna do that.
Sure.
Where is that and all those. Okay. Was that any other questions? All right. Osteoporosis. So we talk about osteoporosis medications, great medications. We use some of them to treat. We use some of them to prevent fractures. So just making sure that you're understanding that when you're looking at your patient, when you're looking at the case on the exam, that you're seeing, hey, what am I doing? Am I doing treatment? Am I doing prophylaxis? We're going to have our ELOs be the same exact things that we talked about. So mechanisms, adverse effects, contraindications, all of those things are the same name of the game. When we talk about these, we kind of have to do a little bit of background with how does this work? What are we actually doing with our meds? What are they targeting? Have y'all talked about some of this stuff yet? With like osteoblast, osteoclast, all of the things, right? So your osteoblasts have a B in it, they're building bone. Your osteoclast has a C, they're chewing it. So they're doing more of the remodeling. When we look at our parathyroid hormone, when we talk about this is like the boss of like all of our remodeling that we talk about in our bone homeostasis, right? So depending on what's happening with your parathyroid hormone, that's what's going to determine what activity you're getting, your osteoclast versus your osteoblast. And that also is going to say, hey, that PTH is like, do I need calcium or do I not need calcium? And that's what's driving the osteoclast versus the osteoblast. If you're saying, yes, I do need calcium, then it takes those osteoclasts and it puts them out there so that it can chew up the bone and release that calcium. Versus if you said, I don't need it right now, it'll send that osteoblast and it will build our bone with that calcium that we have, okay? So just making sure that you're understanding, we have osteoclasts, we have osteoblasts. Our drugs are going to be targeting those things, and we also have some that are looking at our PTH as well. DEXA scans, so these are different scans that we're doing to define, right, the severity of the osteoporosis of our patients, or to just say, do they have osteoporosis or not. I don't need you to know anything except for when you see these are their T-scores. And this is just letting us know, again, the severity of the osteoporosis. So the lower, so like if I tell you something that's like negative 2.5, that's very severe. But I will tell you what they are. I just want you to be aware that this is a scan that is done for us to see what their BMD looks like, okay? So what does my bone mineral density look like in this patient? Because the less that they have, the more likely they are to fracture and easier, okay? So some of our meds will be more aggressive with treating with those versus other meds where it's like, oh, she's at a -1. Is she not too bad versus my person who could be at like a -3, right? They're super severe and they're more likely to fracture. This is a summary slide showing you where your medications are working when we're talking about osteoporosis. So looking at this, you have our treatment that we're using. When you see anything that is positive, that's us trying to preserve the bone. When you're seeing the things that, like our glucocorticoids, right? So these are going to be things that can impair our bone formation, and they can impair the function of our osteoblasts. So that's why sometimes you'll see that these are not things that we want to have for a long period of time. And we'll talk about steroids in more detail later. Looking at our bisphosphonates, we'll talk about those and how those work. what we're trying to target there. And then we go over a couple of these other medications. Our estrogens you're going to see in our SERMs is what we kind of call them. You'll see some of those more in this lecture and in our next lecture. So this is just giving you a background, remembering that your osteoporosis is going to be a condition that we are typically seeing in patients as they get older. Okay, when you're talking about your osteopenia, that is essentially my bone, I'm losing my bone mineral density, right? So my bones are getting weaker, I am more fragile. I am more fragile and likely to break. So that's all I need you to remember here. We'll talk about the drugs in the way that I want you to remember them. But again, this is just giving you a little bit of pathophys for you to know what's going on. My lifestyle modifications are very important. If I have a poor diet, if I don't have the proper amount of calcium and vitamin D, when you're younger, you get away with it. When you get older, you don't get away with it as easily, right? So making sure that we have them on their normal daily dose of that vitamin D and the calcium that they need is going to be very important. If somebody is taking a multivitamin, this should be in that multivitamin that they're taking. But if they're not, and they say like, oh, I don't take any supplements, and you start to see that they're becoming osteopenic, then we're going to want to put them on our calcium and our vitamin D. Looking at our bisphosphonates, these are drugs that we love when we're talking about osteoporosis. There are certain situations where we cannot use these medications. And we will go to some of our other medications that we're going to talk about, which are our selective estrogen receptor modulators. We have parathyroid hormone that we can potentially use. And then some of these other ones like your Prolia, your calcium salmon nasal spray. But for the most part, your ideal patient, you want them to be able to tolerate a bisphosphonate. So all of our bisphosphonates that we have, you see that they end in dronate, right? Alendronate, risedronate, ibandronate, and zoledronic acid. The first three are oral options that we have. The last one is an IV medication. So they would have to go into an infusion center or come into the clinic to get that, that medication infused for them, okay? And then we're going to go over looking at some of our SERMs and how they act and what they're doing. We want to, when we talk about hormones, and we'll talk about hormone therapy a little bit, you want to reserve estrogen because it comes with a lot of side effects. And for some patients, especially patients who are at risk of different type of thromboembolic events, this is something that we're very cautious with and we're worried about. Also depends on where they are, if they have their, if they are, oh my gosh, I can't even think of the word, I just lost the word, y'all. So just know these, we reserve them. Our two drugs that fall under our SERMs that we're going to talk about for this are going to be your raloxifene and your conjugated estrogens that we have. That's what I was looking for, menopause. We also worry about menopause. And when you can, see, I just got older and now I'm forgetting stuff. This is not feeling good for me. I don't want to talk about osteoporosis today. So when you're looking at this, that plays a role, right? Because those hormone levels are going to be changing, and we're talking about estrogen and stuff when we're looking at menopause. So that's why you're seeing some of this, and we'll go into this a little bit more. When you're talking about your SERMs as well, just make sure that you're understanding that these are drugs that act like estrogen, or they're going to block the effects of that estrogen in different tissues, okay? This is what I was telling you about your calcium and your vitamin D. So just making sure that they have the right amount of calcium and vitamin D that they're supposed to. This does vary depending on the patient's age. It also varies for children. Okay, their doses are a little bit different. So looking at your calcium doses, all I want you to understand from here is that they need calcium, they need vitamin D, and looking at where you see what our recommended dose is. So for our vitamin D, you have 400 to 800 international units, and for if they're less than 50, and then 800 to 1,000 for your patients who are older, because those are our patients who are more likely to be deficient. Those are our patients who are going to start to have that BMD decrease, right? As I get older, my BMD starts to go down. So therefore, that's why you see that recommended dose increasing, okay? Make sure that you are telling your patients to exercise, okay? Don't tell me when I'm 70 and I haven't been to the gym in 10, 15 years to go and start like lifting heavy weights. because now we have injuries. I'm 70. I haven't been working out. Now you have some 70-year-olds who they go in there and they've been working out. They never stopped, right? So those people, you just continue to encourage that for your patients who have not been doing that, you get them back into those habits, okay? Because the more that you have that muscle built up, the less pressure and stress you have on your bones, okay? So that helps kind of strengthen their bones as well. Smoking, we all know that we're not supposed to smoke. Their weight, make sure that they're watching their weight, and then also trying to avoid steroids as much as we can, because those steroids are going to impair that bone mineral density as well, okay? And we don't want that to happen. If they have to have a burst of a steroid, that's typically okay. We're talking about something where they're on it for a longer period of time. Calcium, just understand that I want 1,200 milligrams of the calcium daily. There are several different ways that they can get calcium. We also have calcium in the pharmacy, just like we have the vitamin D. So just make sure that you understand that 1,200 milligrams. That's all I need you to understand from here. Sometimes if our patients are taking too much calcium, what you will see is that they can end up having constipation, they can get dyspepsia, things like that. So make sure that they're staying around this normal dose. They also can be getting it from their diet. So it's not like all of this has to come from a supplement. Okay, our vitamin D, we already talked about this. But if you have a patient who comes and they have low vitamin D levels, what I like to tell y'all is to don't tell your patient to just go outside, right? Because then the sun, we're worried about cancer, make sure that they have on sunscreen. You'll have some people who are more melanated, they're darker complexion, and they're like, I don't need sunscreen because I don't burn. They also need sunscreen. I need sunscreen, okay? So don't just think that, oh, like this is for certain people, like this was a thing that we used to do before. And in certain communities, they do feel like, oh, I don't need sunscreen, so stressing the importance of that is very important. Also, it's great for your skin. It's a great moisturizer, okay? So again, when we're talking about our vitamin C, our vitamin D, we're just supplementing when there's not enough in their diet already. So when you get those labs, if they have been eating how they're supposed to eat, then you should see what's kind of reflective of where they should be, and then you can pick the vitamin D that you're going to use. We do have a prescription form of vitamin D that is available, and they would take that tablet instead of taking the lower dose, which they take every day, and they can get it over the counter. We also have it in the pharmacy. But we have a capsule that is 50,000 IUs. So this is for your patients who are like very deficient, right? But what you have to make sure of is that you're telling them that they're taking it once a week. If they don't remember that and they take it every day, they have problems. My mom did this. She was like, they only gave me 4 of those little pills and I'm already out. But I don't think I like them anyway. My body is just hurting really bad. It was like 4 pills. What do we give 4 pills for? And I was like, do they tell you have low vitamin D? Yes. You took it was it green? Yes. You took it every day? Yes. What does the bottle say? Where is the bottle? Look at the bottle and say, Mom, can you read this to me? Take 1 capsule by mouth every week. So why did you take it every day, ma'am? This is another one that we have where people will take it every day. Anytime you give something that they don't take every day, make sure that you give them the day. You say you take this every Monday, and just every Monday. And you can write that out instead of saying take once a week, okay? Remember, I'm getting old. You have to be very specific with me and tell me what you want me to do. So you will say, hey, take on every Monday. Whatever day they want to pick, you say, hey, what day would you like? So that way I feel included, and then you tell me to take it that day. This is just showing you the breakdown. Y'all will go over this, understanding that your body is only going to absorb that calcium whenever you have the vitamin D present. So just trying to make sure that they have both of those things so that we can have good bone health, good bone remodeling, and homeostasis. So you will learn this in another class, just there for our completeness. When we're talking about our estrogen replacement therapy or our SERMs that we have available, what we're doing here is we're stopping the reabsorption and increasing the bone formation. So when I say I'm stopping reabsorption, I'm trying to have my osteoclasts stop chewing. I want them to stop. And I want to increase my bone formation, and typically I can do that with my osteoblasts, right? Or if I stop my osteoclasts from chewing and my osteoblasts are building without my osteoclasts chewing, now I'm unopposed. And so I have an indirect way that I'm building that BMD, okay? So this is, again, helping reduce fractures. I do want you to pay attention to what type of fractures these are effective in, because some people are more prone to fracture in different areas. So hip, spine, and non-vertebral locations are where you can see your SERMs work. We have very few drugs that are going to be good when we're talking about vertebral fractures, okay? So that's what you're paying attention to here. So any fracture essentially that you're looking at that is not in the spine, your SERMs are very good options for us to use. The higher the dose, the higher your BMD will increase while they're taking that medication. When you pull this medication, you should be able to, or you don't want this to happen, but what you will see is that BMD is also going to start to decrease, because now your medication isn't controlling that osteoclast and osteoblast activity, right? So it makes sense that when I take this off, I'm going to see the loss of that BMD that I just built up, okay? So when you're looking at this, make sure that you're understanding, and we talk about this because when you look at bisphosphonates, when you stop a bisphosphonate because it has such a long half-life, you don't see this dramatic decrease as soon as you stop it. Whereas with these don't have those super long half-lives, so that's why you see that almost very quickly, the protective effect that you had from that SERM and building that BMD starts to go down quickly, okay? Our clinical use, this is just looking at your patients who are great candidates for using our SERMs. So when we talk about this, we have our patients who, so this is where I was trying to find the word menopause, right? And making sure that you understand when you can use them and when you're not using them. We're gonna get into a lot of detail when we start talking about like our different hormone replacement that we have. So when you are looking at this, you have your patients who are taking this when they were during menopause and they were staying on them for a very long period of time. We started to do studies, and what we started to see was that in some of these situations, you would have an increase in a lot of thromboembolic events. And so we started to get more specific with how we use estrogen therapy because of the side effects. These have a lot of side effects that can be very serious. So if you are with someone who's been practicing for a very long time, they were like estrogen heavy. Like we would throw hormones at everything. And as we started to get a little wiser with our medicine, we started to say, hey, when we're looking at our estrogen components, the higher the dose of estrogen that we're giving someone, the more likely we are to see these VTEs and cardiac issues occurring. So that's why when we put someone on these medications, we don't want to leave them on there for a very long period of time, and we start with the lowest dose first. So lowest dose after I have completed menopause, okay? So post-menopausal. When you're looking at this, you'll also see when we start talking about menopause that we can use this to control the vasomotor symptoms that some of your patients will be feeling. So like hot flashes, sweating, like their night sweats, that's what our vasomotor symptoms are. So we will see this drug again, so make sure you're remembering this drug class. Contraindications, if I have a history of any of these types of VTEs, then I'm going to be very cautious. If I have a history of cancer, make sure that you're also being very cautious. This undiagnosed bleeding, genital bleeding, anytime somebody is bleeding, you need to figure out what the source of it is, right? So if I am bleeding because you have given me estrogen and now you have caused me to have an imbalance, that is different than if I'm bleeding because I have some type of infection, whether it is an STD, any type of infection. I need to find the underlying cause. So once you figure out why someone is bleeding, okay, you treat that issue, then you could potentially start this, and yes, you could potentially see that they can have bleeding occur from you putting them on this medication. But it's not a lot, it's very light. So contraindications, VTEs, cancer, undiagnosed bleeding, vaginal bleeding that they have, okay? Postmenopausal women, we want to stay at a low dose. We want to not leave them on these medications for a very long period of time if we can help it. Looking at our two drugs that we have, and we're specifically talking about our osteoporosis, this one is going to focus more so on our raloxifene or our Invista. It's an oral tablet, very small tablet that they can use. Again, you can use it for your prevention and your treatment of osteoporosis, but we're making sure that the person has already gone through menopause. So post-menopausal, okay? If they are at high risk of breast cancer, you can see where sometimes we can use this because this does reduce the cancer because it's binding to, this drug specifically, is binding to the estrogen receptors to kind of decrease the amount of estrogen that is feeding into the breast cancer. Okay, so it depends on what is the etiology of their cancer. So if they have one that is estrogen based, this is going to block that estrogen from binding to the breast tissue. You also see that you have your postmenopausal women who can't take bisphosphonate treatment. So some of your patients will not want to, they may have poor renal function. They may not tolerate a bisphosphonate very well. Everybody does not tolerate them well. So if they cannot tolerate it, even though we say, I love bisphosphonate, even though I love them, if I can't tolerate them, if I'm not going to be adherent to my treatment because I don't like how I feel when I take it, or because my renal function is poor and it's not going to get back up above 30, because 30 is what we're going to look at when we talk about our bisphosphonate, this is an option for us to use. Looking at our contraindications, same things that we talked about here. If you're worried about hip fractures, because we don't get very good responses from these medications, this is not one that we're going to put them on to prevent a hip fracture. And then you see we're not using it in anyone in their premenopausal stage. If they're pregnant, contraindicated, okay? So postmenopausal is the big thing when we're talking about our SERMs. Our interactions, when we talk about our bile acid resins, remember those could decrease the absorption of almost any medication that you're talking about. But in this situation, because we're using it for something that's critical, like decrease BMD and increasing the risk of fractures, that's why we're making sure that we're annotating that there. Your warfarin, remember our warfarin, we had to make sure that we were staying inside of that therapeutic window. So if you added a SERM to somebody who is taking warfarin, we can see where we may need to adjust the dose of our warfarin for that patient. And then our thyroid hormones, not saying that we have to absolutely avoid this medication, but we are going to have to separate them. So that's why you see that 12-hour separation. So you can take, one in the morning and one at night, but just not together. Because some people, we like to take our medications together. So just making sure that you're paying attention to that. Looking at our wonderful bisphosphonates. So these are the ones that we like and we prefer to use. When we're looking at this, this is binding to essentially the surface of the bone. And then when the osteoclasts come and chew up that bone, they will have a taste of bisphosphonate and then they will blow up, they will explode, okay? So that's how I try to remember my bisphosphonates, all right? So they lie in our bone matrix, and then when the osteoclasts come and they're chewing, they're eating your drug. And your drug is like, haha, got them. And then they will go through apoptosis, okay? So that is your mechanism of action when we're looking at this. It's decreasing your osteoclast activity, right? Because as they're chewing, they're getting your drug into them, and then they're going to explode. They're going to go through that apoptosis. But this isn't directly doing anything to your osteoblast. But now it's allowing your osteoblast to just build without anything chewing it away, right? Without that bone getting degraded. So now I'm able to increase my BMD because my osteoblasts are working in peace. They're not competing with my osteoclast who's doing that reabsorption, okay? Or your resorption. Let's take our break and then we'll come back. So I had some questions about the SERMs, and the reason why I don't go into a whole lot of detail with those and all the several nuances that they have is because we'll talk about them again in hormone replacement therapy, and that's typically where we like to use them. We don't love to use them in a condition like osteoporosis. One, the effects aren't very lasting. Two, we don't want to use them for a very long period of time, right? Most of your patients who present with osteoporosis, they will be postmenopausal anyway, so that's the plus about it. But these aren't things that we really like. We don't really love to use our SERMs in these situations. You have to know what your options are if you cannot use a bisphosphonate. So your number one thing that we love is gonna be a bisphosphonate, and coming in the rear and like kind of coming up is also our Prolia, that they're starting to like to use that as well. So we're gonna go over that a little bit more in detail. So first line, for the most part in our patients who have osteoporosis, you'll see that we also have different types of diseases. Some of them we use off-label, and essentially what we're trying to do is say, hey, I want to try to decrease, so any condition that you can think of where their osteoclast activity is increased, we can use this. Most of them are going to be off-label. So I was telling you guys about my daughter, she has osteogenesis imperfecta, or brittle bone disease, and so this was the drug that we had to use for her because there was nothing that's for that disease directly. So what it's doing is it's trying to say, hey, I want to stop this osteoclast from chewing up the bone and try to allow the osteoblasts to work as much as they can to like strengthen it, okay? So that's why we like our bisphosphonates. The other reason why we like our bisphosphonates is because it has a very long half-life, possibly all the way up to 10 years. This is the longest thing that we have ever seen in any of our drugs that we talk about. Some of them I'm like, oh, it lasts for 30 days, that's a long time. This is a real long time, right? So 10 years. So when you're looking at this, and if you ever look at like an x-ray of someone who has been using a bisphosphonate, you see what's called zebra lines. So any infusion that they had, if they do the infusions, which we can talk about some of these that have an infusion option, you'll see like this darker white line from their infusion that they had, okay? So these are, again, very good medications for the most part. They are tolerated very well. And then you see that when we're talking about our clinical uses, these are some of the ones that will help with remodeling the vertebrae if they are decreased or compressed in someone who has osteoporosis. So think about like a marshmallow as one of your vertebrae. And when you have a compression, or as they start to have osteoporosis, you'll start to see that it's kind of getting smushed. So imagine like you smashing a marshmallow. When you're using a bisphosphonate, the idea is that you'll start to try to rebuild that vertebra and make it back into the shape that it's supposed to be. So my daughter has 3 breaks in her vertebra, and so they're compressed. And so when we're trying to give the bisphosphonate is to see if we can get that normal marshmallow shape back, right? Like the normal shape back instead of it being like this. So we don't have a lot of drugs that are very effective at doing it, and it takes forever to do it. But they are good options for your patients who have those vertebral fractures and trying to repair them, and also trying to prevent them. They're very, very effective. When you're looking at your abandronate, you will see this sometimes used off-label for other things, but specifically looking at abandronate, we're trying to refocus our abandronate on our vertebral column and our vertebral fractures that our patient has. So that's the difference between your ibandronate is isolated to your vertebral fractures versus your other bisphosphonates, which you're using, for any fracture essentially that your patient is having. Looking at your treatment duration, because we have this very long half-life, the amount of time that you're going to give a bisphosphonate will vary. You will hear different things. The more severe, the more likely you are to use this for a longer period of time. So where you're seeing this treatment of 5 years, this is going to be for most of our patients. We get up to 10 if you're like, hey, I tried to take them off of this bisphosphonate, they started to fracture more again. Or they have a very, very low T-score. You'll also see where sometimes we'll put them on this medication again for a longer period of time. Remember that half-life in this drug is continuing to accumulate in the bone. So you're going to have that residual effect for a very long period of time when you're giving this medication. Contraindicated in our patients with a creatinine clearance less than 30 is a big thing when we're talking about these. This is why some of our patients cannot take the bisphosphonate. Okay, they can't tolerate the bisphosphonate because they have poor renal clearance. Our adverse effects, just think about a lot of GI disturbances when we're looking at this. So whenever they take their medication, what you're going to tell your patient is to make sure that they're sitting upright for at least 30 to 60 minutes. When you're looking at that, we have an exception. Most of our drugs are at 30 minutes. Again, when we just talked about our abandronate is isolated to the vertebral column. Our abandronate is also where you'll see that they're sitting upright for a longer period of time. They'll stay upright for an hour, for 1 hour. Okay, so your abandronate is like your exception when we're looking at our bisphosphonates. Osteonecrosis of the jaw. So typically you don't see this, but it is an increased risk. So because you have that unopposed action of your bisphosphonate essentially happening, what you'll see is that they can have necrosis of their jaw, specifically if somebody is going into their mouth. So the dentist is going into their mouth and they're doing a dental procedure. So you'll have where on some of your dental forms, if you ever pay attention, it'll ask if you're taking a bisphosphonate. And if you have a patient who's taking a bisphosphonate and they go to the dentist, just make sure that the dentist is aware that they are doing that. Looking at your atypical fractures in the esophageal cancer, very rare that this is going to be something that happens. When we talk about trying to prevent this, that's why we also see that 5-year mark where most of our patients are getting off. You're less likely to see this. So for your more common thing that you see when we're talking about our bisphosphonates are those GI disturbances. We have these one-offs when we're talking about these fractures and the osteonecrosis of the jaw. Your interactions, again, just making sure that they're sitting upright after they take it. They should also be having the full glass of water. So for most of our bisphosphonates, it's 30 minutes. Your abandronate is the one that they're going to have to be up for 60 minutes, okay? Remember, we just talked about the fact that they can have that esophageal cancer. So the way that I try to remember the bisphosphonate as the one that they have to sit up is that if they take that pill and they lay down, it's just sitting right here, right? And then that medication just gets to work there for a longer period of time and cause cancer. That's not really how it works. That's how I connect the two together, okay? So esophageal cancer, when we're talking about our bisphosphonates, so we want them to sit upright 30 to 60 minutes. The only one that's 60 minutes is your abandronate. Y'all are going to have to remember a few doses, okay? These are the doses, and I'm going to help you remember the difference between the two. So you have alendronate, risedronate, ibandronate. These all have oral options. Your ibandronate also has an IV option. And then your Zol or your zoledronic acid is only IV. So this is where your patients are coming in to get that infusion. You see that I can use these in both prevention and treatment like we discussed before with our bisphosphonates. If I'm using it as a preventative, right, I have not had a fracture, you're trying to prevent me from having a fracture, you see that that's prophylaxis, right? So my dose is lower than if you were actually trying to treat me, my dose is higher, okay? Because I've had something happen already, and now you're trying to treat me. Versus prophylactically or prevention, I haven't had anything happen, I'm at an increased risk. So, when you're looking at this, you can have a daily dose or you can have a weekly dose. If I want to take something every day because it's easier for me to remember, we have these pills that they can, and it comes like, we can give them in a bottle, and it'll come with just that 30 that they're taking for that month, okay? So that's a daily administration. And then we have the cards that they can get if they're doing the weekly administration. And it'll have 4 tablets in that card, and then that's for them to take once a day, once a week, okay? So make sure, again, when you're doing that once a week dosing, that you're telling them which day they're taking it, because they will forget. So on the label, we'll typically say, hey, the doctor wrote that you're taking this every Monday. Again, get your patient involved. What day is easier for them to remember? Oh, I want to take it Sunday after I come home from church. Great. Every Sunday you take it, right? So you just talk to them, see when they are going to remember, because compliance is the key with these meds. If they are not taking the med, then we are not going to prevent that fracture. And then they're going to end up on this medication or hopefully not in surgery because they had a horrible fracture, okay? So looking at your prevention, 5 daily, and then you're doubling that if you're doing treatment, okay? And the same thing whenever you're looking at weekly. If you remember 1, you just times 2, and that's giving you your treatment dose, okay? So your prevention is half of your treatment dose, okay? Looking at your risedronate, same exact thing, right? You have the 5 that they could be taking daily, or they could be taking 35 weekly, and then looking at your 75 on 2 consecutive days, once a month. That is an option if your person is like, hey, I don't want to take anything every day. I don't want to take anything every week. I want to take this once a month. Okay, so then that's where they're taking those 2 tablets on Monday and Tuesday, or Thursday and Friday, whatever they choose. With this option, if they do that, they are getting a very, very high dose, and they are likely to experience a lot of GI discomfort from that higher dose. So if you have someone who is complaining of the side effects, the daily dosing is better, of course, than taking that higher 1 weekly dose. Okay, so that's where you would try to persuade them instead of trying to switch them to one of your other medications, if you can. Now you have your ibandronate or your Beniva. Your Beniva, this one they're only taking once a month, and then we also have our IV option where they would come in and you would infuse them every 3 months for their treatment. Making sure again that you're paying attention to the fact that we are typically using this for women. We're talking about our ibandronate. So you see how ibandronate has come up several times where we're not doing the typical things that we've done with all of our other bisphosphonates, right? And then your zoledronic acid, depending on how severe or osteopenic your patient may be, you can see where sometimes they will infuse this more than once a year, but for the most part, most of your patients are just getting 1 infusion once a year. Hey doc, I don't feel like being bothered. I know that I have osteoporosis, and I know that you say you want to treat me. Can I just come in? Is there something that you can do where I can come in once a year and I can get this infusion and I'm out? Okay, so this is a one-time infusion that they're getting once a year, and then the next year they'll get it again, and they get it again. Remember, we're limiting to 5. If I'm very severe, then you can go up to 10. Most of the time with our IV options, we're saving this for our patients who cannot tolerate or who do not want to take the oral option. Okay? So we do try to start with our oral before we are trying to do IV. But if the patient wants to do that, then we can accommodate. Making sure that you're looking at this when we're talking about the duration, okay? So understand your duration, understand what your routes are, okay? Understand what your doses are. That your treatment and your prevention are going to be different. And I'll let you know, because I may just want you to understand the difference between your daily and your weekly, but I'll look. Looking at your drugs that we have, okay? Again, same exact medications that we were talking about. Everything is now here on your summary chart for you. If you're looking at your indications that you have, you're, again, prevention and treatment. Remember that you have the option for both. The dose for your prevention is lower than your dose for your treatment. Any of your diseases that you could potentially have where you're worried about the osteoclast activity, you're trying to increase that BMD, you can use a bisphosphonate in it. It's probably an off-label indication. Looking at your ibandronate, remember your ibandronate is your exception to everything. You have to be upright for 60 minutes. I have also an IV option, just like with my zoledronic acid, I have an IV option for my ibandronate, and then this one is for your women as well, okay? Full glass of water, 60 minutes upright. I have an IV option, women. Then your Zol, remembering this one was the one that we had the treatment that we could do for once a year, IV. This is not something that they're taking home, the zoledronic acid. They have to come in. And then your indications are essentially the same. I just want y'all to remember for this, I'm not going to go into like the difference where it's telling you like glucocorticoid-induced osteoporosis. I'm not going to do that. Just remember, we got it for treatment and prevention of osteoporosis, okay? Looking at our comments, big thing that's standing out to us here is what we already talked about. If they have that poor renal clearance, so the creatinine clearance is less than 30, then we're not going to want to use a bisphosphonate. We're going to talk about some of our other meds. We already talked about one. We had our SERMs, but we don't want to use our bisphosphonates in these patients, okay? And then some of your other indications are listed here. So your patients who can't swallow, right? If I'm taking an oral medication, I have to be able to swallow it. If I cannot and I have osteoporosis, then what are my 2 IV options that I have? Don't make that face.
Beniva and Reclass.
Ibandronate and our zoledronic acid, right? So we have 2 options that I can give for them. Yes.
So is that saying that the creatine clearance, is that a hard contraindication or not?
Don't start doing that, guys.
It said not recommended.
It's not recommended because we have other drugs that are going to be available, and when we get to those drugs, you're going to know what they are, and we'll talk about them. But do not use these. And I keep repeating, do not use these in the patient who has a creatinine clearance that's less than 30. Also worrying about your patients who have hypocalcemia, because this could be something that interferes with their calcium and further depletes their calcium levels. So if you are doing this, you need to restore those calcium levels and make sure that they are maintained while they are on a bisphosphonate. So they may have to do a bisphosphonate with like that vitamin D or or vitamin C to help them get those levels to where we should have them, okay? So watching out for those calcium levels, and then I already told you about this calcium D, so vitamin D, calcium D. Vitamin D, if they have low levels, we're trying to correct those things prior to us giving them these medications because it can worsen it for them. And then our IV options, again, they're the same exact things that you saw, but these are more so indicated for our patients who don't want to take or they cannot for some reason take an oral option, then we will do our IV. So here is a 70-year-old male. He is very, very osteopenic, right? His BMD is very low because his T-score is a -3. No previous fracture. Clinical team is considering beginning treatment with an oral ibandronate. What's the most appropriate step? Bravo, right? Clearly it's not. So why not A? Right? He shouldn't have been on it in the first place. Why was he on ibandronate? So there was something wrong because our ibandronate, we said, was for our postmenopausal women. What else did we say about our ibandronate? How long do I have to sit upright?
60 minutes.
60 minutes. What else did we say about our ibandronate? Right. Only vertebral fractures. It only included my vertebral fracture. Okay. So remember that that's your exception. If you remember that exception, all of the other things for your bisphosphonates fall in line. I have IV option as well for that one. Okay. In this patient, what's another medication that I could use for this person who's very severe, and it's an IV medication? Zoledronic acid, right? And I mean, yes, we need to start treatment. So this I want you guys to talk through these with me because some of the ways that these checks on learning, I'm like, make it more interactive. Okay, this is a medication that is more expensive, but now that it has been around for a longer period of time, you will see where we do prefer to use this medication sometimes as a first line as well. So let's talk about our denosumab or your Prolia. It is a sub-Q. You see the mAb, so monoclonal antibody is a part of this, the class. So it's a TNF receptor family. So what it does, RANKL is a receptor activator of nuclear factor ligand. And so what this does is it binds to your RANK receptors on your osteoclasts to increase their activation or their activity. So my osteoclasts, did they build or did they chew? They're chewing, right? So they're decreasing my BMD. So therefore I'm having less bone, and I don't want that, right? I already have osteoporosis. So when I use this, my monoclonal antibody that binds to my RANK ligand and inhibits this osteoclast formation, now I'm allowed to have my BMD increase because my osteoclasts are not around chewing up everything, right? So now I'm giving my osteoblast a chance to work. So the Prolia binds to that RANKL, and therefore the RANKL can't bind to RANK. And therefore, now you are going to have your osteoblast being able to work without going against your osteoclast. Okay, that's our mechanism of how this is working. When we look at our clinical use, again, not something that is typically first line. What we are seeing, because we are increasing the data that we have available, so because this was a newer medication, we didn't have enough. Now what we're starting to see, and what some of the studies are coming out to say, is if you have somebody who has a very, they're at a high risk. So this right here, used as initial therapy in patients with a high risk of fracture, and they cannot tolerate one of my bisphosphonates. They have poor renal clearance, so they can't tolerate the oral, or they have poor renal clearance and they can't tolerate a bisphosphonate at all. You will see sometimes in some of our guidelines that will tell you to go directly to your Prolia as a first line agent, okay? But if I can take a bisphosphonate, I am going to prefer the bisphosphonate, okay? So this is like a alternative to bisphosphonate that could potentially be a first line. It does cost more money, okay? But remember, we have our monopoly money when we're talking about our MTFs. And we're now getting outside of just those GI disturbances that are very common when we're looking at this medication. So here, you see that some of your patients will start to explain and complain about like aches and pains throughout their entire body. You'll see that the cholesterol levels may be out of whack, so they'll start to go up. This is just due to the mechanism of the drug. And then sometimes you can also see where your patients will have cystitis. So again, it's an injection. Typically your patients will get this injection every 6 months. Costs a lot of money, but this is a good option for someone who is either very, very severe, so they're a very high risk patient, and they cannot tolerate that bisphosphonate, whether it's they don't like the side effects, their creatinine clearance is low, or they don't want to swallow the bisphosphonate and they don't want to use the IV option. This is a sub-Q option. They can do this at home. They do not have to come in the clinic to get this this medication. When you're seeing that hypocalcemia, yes, it is something that is less common that can happen, but you can see this occur more than we would potentially see with our bisphosphonates. Remember, we were worried about their calcium and their vitamin D levels there as well. So you're more likely to see this if one of your patients has like chronic kidney disease. You're more likely to see this, and it is something that is typically less common, but in that patient population it becomes more common. And then the oversuppression of your bone remodeling because of the mechanism in us impairing, right, that rank and how the rank typically would work, we're messing with the homeostasis. So you can potentially see where some people will have that suppression occur, and then the same atypical fractures, the osteonecrosis of the jaw, those same things that we were worried about with our bisphosphonate, we start to worry about here, okay? And then you have some not as serious issues, but your dermatologic effects, and then your immunosuppression. Remember, because this is a MAB, a monoclonal antibody, you will see that occurring. Contraindicated again in our patients who are pregnant, and then our patients who have low levels of calcium. We would have to correct all of that first. Calcitonin, not something that we would typically use as much anymore, but parathyroid hormone is secreted when we have our low levels of calcium to free it from our bone, because our osteoclasts are going to go, and it's going to, osteoclasts are going to go ahead and chew that up. And so your parathyroid hormone will decrease with your high calcium levels, right, because it's trying to store that calcium level. So that's where you'll start to see some of your osteoblasts try to start building again. So when we're talking about calcitonin, this medication is antagonizing your parathyroid hormone release, and therefore you'll have that osteoclast via your osteoclast activation. And then you'll see your increase in your BMD, specifically looking at your vertebral and your femoral sites that the patients will have. So not very helpful whenever we're talking about our patients with hip fractures that we're trying to help resolve. Also understanding that if anybody has any allergies to fish, that this does come from salmon, and so they can potentially see reactions to that as well. Some of the patients, and this could be because it is helping with the vertebral fracture and kind of repairing it, where you can see that some of the patients will say that they do have some pain relief whenever they use the calcitonin if they experience those vertebral fractures. So again, I told you this is not something that we typically love to use, so I wanted you to pay attention here to our mechanism of action. It is something that does have an FDA approval for osteoporosis, but like this is not something that we will recommend often. So when you're looking at this, just kind of think of this as one of the drugs that you can use to throw in the trash. It helps them a lot with the pain, that like with their vertebral fractures. It's kind of where you'll see this. There are some people who are still on this medication, which is why I have left it in here, and I still don't take it out. Okay, so you will potentially see this. If you do see this, just try to get your patient off of it if you can. If you try to take them off of it, and they start to complain of that pain and stuff again, then you can put them back on it. But it's not one of our more effective drugs. It used to be, which is why you will still see it sometimes. Your teriparatide, or your Forteo, this one is a sub-Q medication that we have available. Very good drug, a very expensive drug, but one of our last lines. So again, this is looking at that parathyroid hormone. And remember that in the areas, or when we have low calcium, we'll see that this increases. And so that will activate our osteoclast. And then you will see that with high calcium levels, we will activate our osteoblasts. So this injection is something that they're doing every single day. And we try to limit us using this for less than 2 years in our patients. So imagine having to inject yourself every single day versus hopefully being able to use one of our bisphosphonates, or at least an infusion that we're not having to do every single day. This is for, again, our very, very high-risk patients, so something that is reserved for later on down the line. We try to treat them with a bisphosphonate. We try to treat them with any of our other meds, and they did not work. This is typically when we will see our Forteo used. You see the price here, which is probably going up now, $42,000 a year, which is not something that's cheap, especially if you're dealing with patients who are on the outside who do not have insurance, okay? So, again, we love our bisphosphonates when we're talking about osteoporosis. That is the main drug that we are trying to use that we hope works for us, okay? Looking at your contraindications, same things that we've already talked about before. So if they have high levels of calcium, or even enough calcium to where we're seeing it in their urine, we're going to avoid this medication and make sure that we're correcting that. And then you can see that it can increase the risk of cancer in some of your patients. So yes, we're trying to help with bones. We saw a lot of cancer. We saw VTEs. So making sure that you're paying attention to which fractures we are helping with. And when we're looking at our bisphosphonates, how we separate out our abandonate, and everything else kind of falls together. So those are like the 4 drug classes that we have to kind of focus on when we're looking at our osteoporosis. Okay. Don't laugh, because y'all know what I'm about to tell you to do, right? Let's open our next one and get started. I'm trying to give us back time, because this exam is, I want to write this exam so I can tell y'all where to focus. So let's look at, or not study where to focus. Let's look at our thyroid. Y'all have that one uploaded, correct? Okay. Okay. All of our energy is off. Somebody got to help out all of our energy. I was trying today. I'm just like, I am beat. Okay. Our thyroid medic.
There you go.
So when we look at our thyroid controls everything, right? When our thyroid is off, you start to see weight fluctuations. You start to see all different kinds of things happening in our patients. So if you don't know what's going on and you pull your labs, look at your thyroid and figure out what's happening. You will see some levels on here, like on this slide deck. I don't want you to remember what the levels are. I simply want you to know hyperthyroidism versus hypothyroidism. You'll see like TSH levels and all that. Y'all will get into that later and y'all will diagnose. I am going to tell you, hey, this person has hyperthyroidism or this person has hypothyroidism. Go. What drugs? All of those things, okay? That's how we're going to look at this. ELOs, same little ELOs we've been seeing. They're still there. Okay, some definitions, because our drugs are going to target some of these things. When we're looking at our thyroid hormone, remember that this is just directing everything in our body, okay? This is what is controlling how I grow, how I develop. When this is off in children, we see very, very, like, they may have several different delays in development, mental growth, several different areas could be affected if the thyroid is off. And then when we're talking about our adults, metabolically, you'll see where some people will lose weight unexplained, they will gain weight. You'll see some of them are very tired. So like just thinking about this, this hormone and thinking about this organ, like think about our thyroid, this is a very, very important part of our body. Euthyroid, you're going to hear that as we go through. So this is sometimes, so if we have hyperthyroidism versus hypothyroidism, we want somebody to have a euthyroid. So we want them to be right in the middle versus hyper or above or hypo below. Okay, we want them to have the euthyroid, so a normal functioning thyroid gland. And we'll use our medications to either slow down what their thyroid is doing or try to speed up what their thyroid is doing to get those levels to where we want them to be, euthyroid. Looking at your TSH, this is what we will look at, and this is kind of what orchestrates our T3 from our T4. So when you see T4, thinking about that is like the iodine moieties that are put on the thyroid hormone. So when you have T4, it has 4 iodides that are attached versus your T3, which you have 3 of them. And then you have a TPO. These are all different things that are in that pathway that we're going to kind of talk about. We'll also talk about T3 and T4 because when you're looking at your T3 and your T4, sometimes we will have peripheral conversion of this T3 and T4 that can lead to issues as we continue to talk about like thyroid storms and things like that. And then looking at your binding. So when we talk about our thyroid, our T3 and our T4 and our thyroid hormone, you see that they're very bound. And remember, when we're bound, we're in a relationship, we're not doing anything, right? So we're not active. So this is the same thing. Bound, I'm not active. And then understanding that in different conditions, when you have people who are on thyroid medication, so if I become pregnant, you may have to alter my normal dosing that I'm typically taking because my binding now is going to change. So keep that in mind as we kind of go through this and you trying to control your patients who have issues with their thyroid. We talk about T4. This is being solely made for the most part in your thyroid compared to your T3, which you can see that some of this is going to be made in the liver. And what happens is we will oxidize that T4 to T3 in the periphery, so not necessarily in the thyroid like our T4. You see that your T3 has the greater amount of activity when it does go throughout our body compared to your T4, which has the longer half-life. We're talking about this because some of our medications that we use are formulated in a way that some of them resemble more of your T3 than your T4. So when you get your labs back, you'll say, oh, like this person's thyroid level is this. So then you try to pick a drug that's based off of kind of where their thyroid levels are. But for the most part, we pick one drug and we'll talk about that. This is just showing you again that you have this negative feedback loop, and based off of how much thyroid hormone you have around, it will go back into, and then your hypothalamus will say, all right, I don't need any more TRH or thyrotropin releasing hormone, and therefore that will decrease the amount of your T3 and your T4 that will be made. Okay, so just understand that the hypothalamus is in control, and this loop is a negative feedback loop that we're going to talk about. Y'all are going to get this more when y'all are doing urology. So I just want you to understand negative feedback, hypothalamus, whenever the T3 and the T4, whenever that builds up enough, it goes back up. Goes back up and it's like, hey, hypothalamus, I'm good. That's your negative sign. I don't need any more thyroid hormone. Stop releasing my TRH, which is the very start of this cascade. Okay, so negative feedback system. All right, these are all backgrounds, not tested. Okay. Looking at our hypothyroidism. So when we talk about hypothyroidism, what we're saying is, hey, I don't have enough thyroid hormone floating around. Hypo is low. Okay? Hypo is low. When you see this, there's several different disease states that are going to be associated with someone who has low thyroid hormone. So you see you have Hashimoto's here, and then we also have different different disease states that can occur, which is secondary to your hypothyroidism. So like if I have any type of issue with my hypothalamus, right? Because remember, my hypothalamus was how I was starting this whole feedback system. So if there's something wrong and I'm not producing enough T3 or T4 because my hypothalamus has some type of insufficiency, I'm going to also see low levels of my thyroid hormone. So that's all this is saying. This is not something that I'm going to test you on. Just understand we have primary, we have secondary. Most of our patients are primary. Okay, and we're going to talk about the disease states that I want you to know about. When we think about hypothyroidism, think about everything is slow. Hypo is slow because my free T4 is low. Okay, so everything is slowed down. You see that most of your patients are going to have cold intolerance. They're cold. They're going to have weight gain, right? Everything is slowed down. My metabolism has slowed down and now I'm just gaining weight. I ate my hamburger and I immediately see that I ate a hamburger, okay? So slow. And I will tell you again what your patient has. I just want you to remember this because when we look at treatment, sometimes we can send somebody into hypo or hyperthyroidism and they will present with these symptoms. This is showing you a non-toxic goiter that can happen. We don't typically see this in the States anymore because we have put iodine in our salt, which helps us reduce the frequency of seeing this, but you know we're in the military, we go to other countries and y'all may be potentially treating people where you do see these non-toxic goiters. So I just wanted you to be aware of what that looks like. What is happening here is that this patient doesn't have a lot of T3 or T4, right? Hypothyroidism. And so what happens is your body starts to say like, hey, we need T3 and we need T4. Hypothalamus, what you up there? What are you doing? So then you start to see that you'll start to get eventually some more TSH so that you can release more T3 and T4, and then your body will start to stimulate that thyroid, and that's what results in this big goiter that you see here, okay? So when we're doing this with our salt, we're exogenously increasing the T3 and T4 because salt isn't everything that we eat now, okay? Here is our drug options that we have. This is where your test is going to really begin, okay? So you have the background, you understand what we're doing, you understand T3, T4, you understand what I'm targeting, you understand what I'm trying to mimic now in your body. Bless you. So, hypothyroidism, I said hypo was low and everything is starting to go slow, right? So, I need to try to get them more T3 and T4, okay? So, I am going to replace those hormones for my patient. So you have T3, right? Synthetic T3, synthetic T4. This one is a mixture of your T3 and your T4. And then this comes from animal sources, okay? So you have your liothyronine, which is your cytomel, your levothyroxine. This is our drug of choice. This is what you're going to see a lot of your people on. This is Synthroid. It comes in several different options. There are different colors. The tablets are different colors, which correspond to the dose that they're taking. And so I always like to tell my patients, hey, if the color of your pill changes and your provider, so let's say your PA didn't tell you that it should be a different color, or you didn't change your dose, then maybe I filled it wrong, okay? So once you put them on a med, tell them, hey, the color of this should never change unless we change your dose, okay? And it doesn't matter which manufacturer you use, we typically have the same exact color for all of those doses. So your Synthroid is your drug of choice that you have here. Your Liatrix or your Thyrolar, this one is trying to mimic essentially what our body would naturally have, the proportions that our body would naturally have. And then you have your animal sources, which is your desiccated thyroid or your armored thyroid. This one, it comes from pig thyroid. So you have to be very careful with people who don't eat pork, right? So like religious reasons. because this medication does come from it. And when you open it, it smells like it. It smells horrible. I don't even know how people swallow this. I used to hate feeling this medication. Because as soon as you open it, you're like, oh, opened it, it smells, you smell it. Now, there are some people who really like to take this medication and they get good results from it. What's very hard about this is because it does come from pig thyroid, your results sometimes or your response to the medication is fluctuating because I may not have the same exact amount in every single tablet. It's harder for us to measure this, okay? So we typically would not want to start someone on this, and then the big thing that you're seeing now is, again, if I don't eat pork, if I don't want to be around pork, you need to make sure that you're not giving this to a patient because it does come from pig thyroid. So what's my drug of choice?
Levothyroxine.
Levothyroxine, okay? Our mechanism of action, I'm trying to give them back some of that thyroid hormone, okay? Because my thyroid is not working. Hypo was slow, and I'm going, and my thyroid levels are low, okay? So I am just trying to say, hey, give me some more of this thyroid hormone. When you're doing this, it does take a little while for us to see the effects of this medication, so make sure that you're not titrating it before that 6-week mark hits for your patient, okay? So you need to be on it for at least 6 weeks. You'll get new levels of their thyroid, so you'll have your baseline levels, which is how you're going to diagnose them. Wait 6 weeks, and then you're going to put them on their medication. You're going to get the levels again, and then you're going to say, all right, this is what your levels have done. Either this is going to be a great dose for that patient, or you're going to have to alter the dose. Before you alter doses, like I always tell y'all, make sure the patient is actually taking the medication. If they're not taking the medication and you're altering a dose, it doesn't matter, okay? But you need to be consistent. Typically that first visit back, they're going to tell you that they probably have missed some doses because it's new to them if they don't take medications every day. So you can kind of expect to where you're like, okay, I'm going to bring you back again, but we need to make sure that this level is right, so I need you to make sure that you're being adherent to the medication. There are some people who complain about like the medication being activating, so you will see where we tell our patients to take it in the morning if they do experience that. Some people will say, oh, I'll take it, you know, before I eat my food in the morning because we do want it on an empty stomach, okay? That absorption is very, very important because remember, this thyroid is controlling everything. And you'll see a decrease in their absorption if they have food. So that's why it's an empty stomach. So for our patients who do say that this is activating, this is easier for them to wake up first thing in the morning, take it on an empty stomach, and then they wait typically an hour or two, and then they can have their meal, okay? So empty stomach. And then you're monitoring, we already talked about this. If I'm not gonna titrate until I at least hit that 6 weeks, I can't do that without monitoring them every 6 to 8 weeks, okay? So this kind of goes hand in hand. When you're initially starting, that 6 to 8 weeks is very important because that's how you're going to titrate them to the dose that they're supposed to be on, okay? Once you get them stable, then you will change that to where you're going to check their labs every 6 to 12 months. When somebody has been on their Synthroid for a very long time, we'll usually check them once a year. You will see that 12 months where they're getting checked. Or if something has significantly changed and they're starting to tell you that they're experiencing symptoms again, then I would revisit and I would draw labs to see that they're still responding to the medication the same way, okay? So again, make sure that you're watching out for their symptoms, that they're responding to the treatment. Your labs are telling you one thing, right? They're giving you that T4 and your T3, but your patient is also going to tell you a lot because your patient is going to come into you whenever they're getting very, very bad. They're coming in because now they're symptomatic. And most people who do have hypo or hyperthyroidism, they're going to have one of those symptoms that we talked about, okay? We'll start here tomorrow.